Okay, we're going to be talking about the respiratory system and some of the alterations that you will encounter as a nurse. So first off, here's a chest x-ray, and you can see the outline of the lungs. You can see where the diaphragm is across here. It should be smooth. We can see back here the shadow of the ribs. You can see the outline of the heart. Okay, see the clavicles. And this is the side view. See the curvature of the spine. And here is a picture of where you can see a cardiac electrode across the top here. But you can see in this picture, it looks like there's pulmonary edema. See these white patches that are down here, and also cardiomegaly. You notice that how large the heart is, quite enlarged. And you can see the clavicles here in relation to where the lungs are. So you can see why in car wreck sometimes the steering wheel will cause the clavicle to be fractured, and it'll puncture the lung, and you'll get a collapsed lung. So we'll be talking about some of that. Okay, this depicts what happens when edema forms in the lungs. This represents the capillary. This is normal here. A is normal. Capillary going in, and then it turns into lymphatic. So it gets its blood supply and gets mixed in here with the alveoli, and then it takes the lymphatics takes the trash away. And that's what it does normally. That's how it looks. But then you can see that that's the normal relationship here. And then in B, we have an increase in the pulmonary capillary. The pressure is causing fluid to move from the vascular space into the pulmonary interstitial space. So you see all these little things starting to go across that semi-permeable membrane. And then in C, we see the lymphatic flow starting to get chugged up a little bit now. It's trying to pull this fluid out. It's put all its little warriors in here to help pull this fluid out, but it all starts getting congested. And then D, you can see that the lymphatic flow it's all worsening. So we're starting to get left heart failure as a result of this fluid movement into the lungs, interstitial space, and into the alveoli. Just a little picture to kind of show you about that. So pulmonary edema is a true medical emergency. That's that fluid that gets out there in the extravascular areas. And there's several causes. You can see patients they're left-hearted failure. They may have too rapid infusion of IV fluids. Could be some other medical conditions, but look at what the signs and symptoms are. And your book really does not spell out pulmonary edema. It talks about a whole lot of other things, and we will see this kind of combined in a few things, but it doesn't really have a specific place. So I will tell you that these are what the symptoms are. We'll start seeing an increase in their air hunger. The patient will be really getting dyspneic. They see their nose flaring. They see their ancillary accessory muscles starting to be used or retracting. Cough and frothy pink sputum, and that's because of that remember that last picture we showed where the blood and the fluid and all is getting across the membrane and filling up the tissue. So that's some blood that's gotten intermixed with some of the fluid. So they may have frothy sputum, crackles, what we used to call rowels, but now rowels is out, the word is out, so it's crackles, and tachycardia, the heart trying to, of course, we'll be breathing faster probably, and the heart's trying to make amends and work faster too. So, and this is one of those areas that we will see pulmonary edema. Remember when you talked about jugular vein distension, or we will be talking about it in a minute. When we talked earlier about it with tamponade, we saw dry lungs. Well, now we've got the veins are distended and the lungs are wet. You will hear wet sounds. So they're anxious. Diagnostically, we will see ABGs will start showing more hypoxia, and they may put in an art line in this patient to make it easier to draw those arterial blood gases. Let's see. The BNP, which is the B-type natriuretic peptide, you probably seen that ordered on some of your patients, or you will. That's produced in the ventricles when there's a fluid overload from heart failure, so that level will be elevated. Usually, let's see, I've got it written down here, let me find it. It's released when there's a rise, and it'll rise that indicates heart failure. So a BNP of less than 100 pgs per ml rules out cardiac failure, but one greater than 500 means they are in congestive heart failure. So you can see we're going to talk about congestive heart failure, and you can see how the pulmonary edema plays in and kind of gets rolled into several different conditions. Okay, so you see what our goal, or the medical goal is, of course, is to correct whatever the problem is so that we can get these patients feeling better. And these meds, I don't think there's just but one or two that are new to you. Morphine, of course, is to relieve pain, and also pulmonary edema. It's one of the drugs that we use a great deal in this. It helps the patient feel better, and it can help us to get some of the fluid out. Not that it's a diuretic, but in that it can help the patient feel more comfortable, and therefore they won't have to be working quite as hard. Certainly nitroglycerin, all the particulars about it. Lasix's going to be the drug of choice often to help get some of the fluid out. And I know y'all are used to giving maybe 20 or 40 or what have you, but we may be giving, for some patients, we may give 40, 60, 80, 100 milligrams. So, and that is something that we have to give over a slow period of time, a flush over probably 15 minutes or so, because you can remember that Lasix has some side effects, so you might want to look those up in case you have forgotten them. The nitroglycerin, dobutamine, Primacor, Dig, and Natricor. And the Natricor is only used for acutely decompensated heart failure, so when they've got really, really short of breath, and even if they aren't even having any exertion or anything. So it will decrease the pulmonary wedge pressure, so it's used just really short term, usually maybe even just hours most of the time. Okay, nursing management. Of course, there's a lot of things that we are going to be doing for these patients. Giving them oxygen a good bit, like 40 or 60%, or we may even have to have the patient may have to become intubated and on the ventilator. And I know y'all haven't really studied about that just yet, but that's coming real soon. The head of the bed may be elevated, and if we can, if they can be sitting on the side of the bed or something. That would be on the earlier stages, because sometimes once they get past that early stage and start really getting wet, you're not going to have them dangling on the side of the bed. Certainly we're going to give them meds, and we're going to be monitoring for the side effects for those, and certainly psychological support for them, because this is a very, very stressful time for them and for their family, but that impending doom kind of feeling that they will have. And certainly we'll be doing monitoring, CVP monitoring, or hemodynamic monitoring often on these patients. And you can see that if these patients are not treated and we don't do some interventions pretty rapidly, they will go in a downward spiral very rapidly, and can expire on you. Let's see, frequent vitals and assessment, of course. Then as they're getting better and maybe they're able to eat and all, certainly they're going to be on restriction of fluids and also of sodium. So, that's a real challenge for us, because most of us kind of like that salty stuff. So strict INO, and these are some of the things that we're going to have to teach the family and the patient, daily weights. And remember that 2 pounds a day weight is usually something that we want to let somebody know about. And be thinking about what foods are high in sodium, how you would go about teaching someone how to be on a low sodium diet and how to measure I&O. Those are things that nurses have to do a lot. Okay, so we're just, and remember, some of this is not new stuff we're learning. We're just learning to apply it to new conditions. Okay, so don't think of it as being so overwhelming. Just kind of read and study and relax and take a deep breath, since we're talking about respirations. Okay, and pulmonary embolism, you can see very often what we'll have is a little clot that has broken off from somewhere, developed somewhere and broken off and moved to somewhere else in the body, very often pulmonary, because that's one of the first places that they'll travel. Often they come from these deep veins, like hips and legs, that kind of thing, pelvic area. So, but they can also come, we've talked a lot about patients with AFib, so certainly they can come from the heart. And what we don't want them to break off wherever they are and go to the brain and cause an infarct there. So we're looking at the pulmonary as being the place where a lot of them will stop. And we're thinking, well, they can be clots, but they can also be air, fat, and amniotic fluid. So those just are some wild phenomenon that can happen to us. And this also is a medical emergency. You will be seeing these patients in your practice, and we'll talk about what we're going to do for them. Of course, we know what the risk factors, some of the real high-risk people for pulmonary emboli are those that are immobile. And, you throw anyone in the hospital and make them lay in a bed, they are very prone to developing emboli. So anybody that's on bed rest, someone with a history of DVTs, anyone that's had some pre-op trauma, pregnancy, obesity, birth control pills, all of those things we know are some of the risk factors. Okay? So what, let me go back, sorry. So what can be the nurses? What is some of the practice that you can do to prevent these from happening? That getting them up early, encouraging them to ambulate, having them do their leg exercises if they can't be up, push against your feet, and tighten their buttocks, all those quad set things that we've been taught from way back. This is when they come into play. Also reminding the physician, hey, they're bedridden. We need to get them on some fragment or something. So, and I think now we're more in tune to that. That's more of an accepted practice, but you may still have to prod some of them along. TED stockings, and just being alert to what the patient tells you. It may not be able to prevent them, but it sure may detect them if they're telling you their legs hurt or what have you. So all those things we've been learning as nursing interventions, now is the time to apply them. This is just looking a little cartoon. If you like it, good. If you don't, ignore it, move on. Showing you how we can do hemodynamic monitoring, art lines, CVPs, the Swan-Ganz for the PAP monitoring. And you see here we've got this little venous stasis down here in their foot, and we've got venous return going to their heart and everything. And how, hey, look, this little clot's gone right here to the pulmonary. It's an embolus stopped right here. So we can see how to diagnose it. They'll do either MRI, VQ, or a ventilation perfusion scan, angiograms of the lungs, and also they go by symptoms also. So, and then they'll follow up with these things. So you can see we don't want it breaking off and going to their brain or anything. So we know we're going to be doing a lot of care and monitoring of these patients. And they are, while they are getting, let me show you some of the, when they have an embolus, see what we've got here. Risk factors, what we just talked about a minute ago. So I'll let you look over those. We've got this guy's with his chest. He's got these lung problems going on, sharp, sudden pain. And look, we've put him on 2 separate lines, not to mix, heparin and saline. We know that. Giving him oxygen, trying to get his blood heart rate down and get some oxygen built back up in his blood because he's short of breath. Look, he's a little cyanotic. Look what his blood gas is. The CO2 is down. The pH is up. And I don't know, it's not the bicarb. That's, I don't know what that is. I can't see it. It's like blurred. But anyway, that's just a little down and dirty of what's going on. So we know we're going to be taking care of these patients. Usually these come on real rapidly. They're very anxious. Their heart rate goes up. They feel like impending doom. Don't leave the patient by himself. Get the crackles, diminished breath sounds, coughing maybe. And usually if they're going to check out, they're gone within an hour. And I'm not talking checking out to go home. They're going home all right, but to the other side. Often have this history of DVTs. So we're going to usually start them on some, that's what we were talking about a minute ago. And the prevention, we know, the keeping them moving, deep breathing, and keeping them hydrated and all those things. But the treatment we're going to do is give them oxygen. We're going to evaluate what their blood's doing, what their gases are, and get these treatments going. And we're going to give them usually heparin to get started. And while they are getting treatments, while it's that acute stage, they are bedridden. So generally, we keep them in bed. We might let them scoot off to the bedside commode, but only with an order. And we'll be watching their heart and checking their vital signs very frequently. And remember, heparin has a short half-life of it's like 3 to 6 hours or something. So, I mean, as soon as you get it started, you start seeing the effects of it. And once you put that in, you can't get it back out. But it doesn't last a long time. So that's why then, after a few days, they start resolving and these clots start reabsorbing and all. They might go on some Coumadin or something before you take the heparin off, because the Coumadin takes a while to get into your blood and all. Certainly they will treat hypotension with Dobutrix or dopamine. And also, like I said, morphine, compression stockings, wonderful, and anticoagulants and thrombolytics. Sometimes they will give some of these TPA kind of agents to these patients to help dissolve those clots. So, let's see what else. Also, they may go in and do embolectomy. May be in an area of the lung where they can go in and pull it out or remove it. And some they will put in, I believe in your book there is a picture of a green filter, and that's like or some will call it an umbrella filter, and it's put into the inferior vena cava, and it helps to keep clots from forming. It kind of causes a little turbulence. It's sort of like I hate to say it, but a strainer is what it makes me think of. Some of them are meant to be put in for short term and then taken out, and some are permanent. So let's see. Now there you go. It's like a little picture, and it's called the nose, and these are the hooks that hook into the vena cava, and then you can see where the blood going through that would keep it from clotting up. So we want to minimize the risk of patients having them, and when somebody starts giving you some, vague symptoms, my legs hurting and all, we need to check it out. Absolutely, because patients in the hospital are very prone to it. Okay. So that's a very much a major nursing responsibility, is to help prevent. So by early ambulation, compression, stockings, avoid sitting, crossing their legs, teaching them to look for the signs and symptoms, and dosing them appropriately with their anticoagulants, if they're going to surgery or coming back post-op and all. So active leg exercises, all that stuff that nurses we need to be paying attention to. course, let's see, hold on. Okay. Did that. Okay, we're moving right along. Just hitting some high spots for you. The certainly monitor for complications. I didn't talk about cardiogenic shock and right ventricular failure. All of these can be added up and kind of as a result of pulmonary embolus. So, these patients can die, and they're certainly very sick, and you must stay on top of them, keeping a really close watch on them. But hopefully they will, with medications and bed rest, they will resolve and do better. Now, some of them may have to wear stockings forever and ever, amen, or they might suggest that they do if they've had history and all. So you'll see they do like a Job's kind of stocking, sort of like what we'll do for burn patients, and it will just really compression stockings, and they go up all the way like to the waist. And they have to be measured and ordered, special ordered for these clients. Okay. All right, moving right along. We're going to move to chest trauma. How about that? It's kind of a more common kind of thing that happens because of people falling or being involved in motor vehicle accidents or motorcycle accidents, that kind of thing. So it's kind of hard to know all the time how much damage they've had, because often there is not a big gaping hole or anything. There's just they've had a big blow to the chest, and we don't know how bad things are bruised or shook up inside. So that's what just happens sometimes when somebody meets a brick wall or a telephone pole or what have you. So they can have fractures to the sternum, also to the ribs, and they can also have like a flail chest, and we'll talk about that in a minute. And pulmonary contusion, just the lung itself, the tissue can bleed and have just a real trauma. So things that you can hit the steering wheel, the seat belt, or just falling can give you some of these injuries. Bicycle crashes and CPR in the elderly. So very often, as you're doing CPR, you might hear bones cracking. We don't not usually hear that in younger, healthy people, but in the elderly, often we will, because they're more frail. Certainly we'll get chest x-ray and ABGs and what have you to kind of give us some ideas. With the flail chest, and you can see you need to go to that box, figure 34-5, to look at that. But the flail chest, what happens is several ribs are fractured, and often it may just be on one side, and it's certainly more common in the elderly, and there's a high mortality to it. And what we'll see is that because when air moves in, because of this chest, several ribs being fractured, as air goes in, the chest moves inward with inspiration, and it moves outward with expiration, and actually it can even kind of balloon out where the fractures are. It's like you can see it, and they call that a paradoxical movement because they're moving the opposite way of what you think they should move, and is extremely painful and hard to get over, and often these patients, especially in the elderly, will have to be, and depending on if it's just one or two, or if it's like all of the ribs crushed, one side, whatever, they may have to be intubated and put on a ventilator to manage their respirations. And then we have problems with getting them off the ventilator. So, okay. We have some looking also at chest traumas. And for those flail chests, they do not usually go in and do surgery on those ribs to repair them unless it's just absolutely gross deformities or something, because they usually have such other problems that they're poor risk, for one thing. But so that's just how it is, and we just have to watch them and monitor them. Because, like I say, you usually have other injuries going along with this. Now, with the penetrating, as you can imagine, there's some foreign object that enters the chest wall, and certainly the ones we're the most common with, or most familiar with, are gunshot and stabbings, and we certainly have those in this area. So, patient's very short of breath, has air hunger, restless. They may have a sucking chest sound at the wound site. So, if there's a knife or a pipe or whatever stuck in the patient, leave it in there. It's kind of like with the eyeball. Don't pull something out of the eye. Leave it, because that may be what's making the difference between going to glory and hanging around here. So do not pull anything out of their chest or a knife or what have you. Just leave it alone and let the MD remove it. So certainly a lot of the complications, what happens with this trauma is that we get hypoxic, hypovolemic, and we may even get cardiac failure. So especially if they've lost a great deal of blood, or if the blood is trapped in the lung, or air is trapped in the lung. So we're really not only just monitoring their respiratory status, we're looking at their cardiac status as well. Nursing is just not for sissies. That is a fact for sure. We're interested, of course, in how did the injury happen, not because we're nosy, but because it relates to how much damage there may have been. Were they going 100 miles an hour, or were they just, barely had just started up and bumped into something? So it depends. And also what other injuries are going on. What was their estimated blood loss? Or did they lose consciousness? Or what's their consciousness now? What drugs were they on? Or were they drunk, or do they whatever, what's going on? What other problems did they already have? What pre-existing problems did they have? But in the same breath, we can't take all day. We've got to do something real quick. So we try to get all the information we can. Maybe a family member or something is there, but sometimes when we don't, we just have to go with the signs and symptoms that we have and do the best we can. And also, not only just drugs that they're taking prescription, what street drugs do they take, or do they have allergies and all? The family and significant others can help if they're available. Let's see. We just have to do what we can do. And you can see here's what we're going to be doing, vitals and what have you, and we'll be getting these clotting times and type cross match, and lights, chest x-ray, CTs, and what have you, and EKG, of course. So certainly we want to establish their airway and make sure, what the integrity of the chest wall. We may have to contemplate doing intubation and ventilation on them. If they have some negative interpleural pressure going on, or a lot of had an injury and got blood in their lungs or what have you, we may have to think about putting in chest tubes. Certainly not us think about it, us assisting with it. So that very much can be. Now when they have that penetrating wound and you hear that sucking sound, there's air going in, but that air goes in and it can't get out. So what we usually do is we will put a flutter dressing on them. That's an occlusive dressing that's taped down only on 3 sides, so that what it allows is the patient to breathe through their mouth or nose and to let air out, but it does not allow that wound in their chest to suck air in. It'll let air out, but not let it in. So that's what we call a flutter dressing, and you'll be tested on that, I'm sure. And so that's with a sucking chest one. Let's see. Sometimes they'll do conservative treatment on these. They'll do whatever has to be done, and they'll do pain control and avoiding any excessive activity, that sort of thing. Not everybody, gets a chest tube. Depends on what all's going with them, what all is going on with them, and how big the wound is, how much air, if they've got a collapsed lung, is it just a little bit? Sometimes we can have like 10 or 15% of a lung collapsed, and if that's so, they often will not put in a chest tube. They will just let it re-expand on its own. But much more than that, and they will put one in. So looking at ribs, that's the most common thing that gets broken on us, or in our chest anyway. Can be life-threatening, but generally it's not. Just hurts like the dickens. Very common, the 5th through the 9th are good sites to get broken. And they usually will heal in 3 to 6 weeks. Well, as you can imagine, that is very painful, and every time you take a big deep breath, it hurts. So conservative treatment would be maybe some NSAIDs, probably not aspirin because it might cause you to bleed, and a binder or some kind of a support around your chest to make it feel better. So that support is a real big deal. Okay. Kind of move back to the flail chest I talked about a minute ago, usually caused by blunt trauma and that paradoxical movement. It's usually when we're looking at the chest, we're seeing symmetry. The chest comes up and down the same. But with that flail chest, it doesn't. It moves inward on inspiration and outward on expiration and balloons out. So that's kind of the freaky thing of that paradoxical movement. And now you can also get paradoxical movement from positive pressure ventilators, being over, your lungs being overinflated. So it can happen. But usually we don't do any surgical repair on the flail chest itself to remedy those ribs unless there's gross deformity or something. Okay. So we're going to do pain control, clearing out their secretions, ventilatory support. Those are going to be our main things. Okay. So let's just go in some more of the same. We're going to be monitoring, watching, giving them pain medicine. Serial chest x-rays, meaning that we're going to be doing them periodically to make sure we're not backtracking. Okay. So coughing and deep breathing, positioning, suctioning are going to be some of our main stuff. Just a little picture, inspiration and expiration. Helps you to see. You can see where the lungs, the chest broken here. See up here? When they go in, respiration goes in, the lung goes in. But then when they breathe out, these broken places, the lung pooches out, or the chest pooches out, not the lung so much. Okay? And you may have taken care of patients with a pneumothorax. You'll be seeing those in the critical care units possibly where you'll be working if you haven't already seen them. Different types of pneumothorax. It can be spontaneous, traumatic, and tension. These are all very scary for the patient. Spontaneous or simple. Usually what we'll see it is usually a bleb, someone that maybe has some COPD, and they just spontaneously happen. They just walking along, not doing anything in particular, working, but not like running marathons or anything, and wham, it just hits them all of a sudden. And I will tell you that people that it really hits a lot are young men, like 25-year-olds that smoke. So let that be a lesson to you. But we do see those often. And sometimes they'll have to put in a chest tube to relieve that so that the lung will inflate again, and until it is able and seals off and closes off, then they'll take it out. Sometimes these patients will have several blebs in there from like COPD, and it's a little harder to get those to close up, and there's a few tricks that they sometimes have to do. Sometimes they'll just have to go in and surgically rough up the pleura to get it to adhere and stick and not keep collapsing on itself. So anyway, then we have those just the different types that it's all spontaneous, but different causes. Then the traumatic, that would be where we get a crushing injury or a pipe goes through you or a gunshot wound or whatever. That's called an open pneumothorax. and you can get that sucking wind like we were talking about, or you hear the rush of air going through, makes that sucking sound. And there again, they'd have to put in a chest tube for that. And it could also be hemothorax, which would be blood instead of air causing the problem. So we'd have to put in, usually when they do that, they put in a chest tube higher in the chest for the air and low, like way down lower for the drainage. And that makes sense. And the upper tube would be smaller and the lower tube would be larger to accommodate for fluid to come out. We'll talk about the pleurovac and all in a minute. Let's see. So we're also looking for other things going on with these patients. If they've had blunt trauma, they may have some other rib fractures. They may have had abdominal trauma, with the stab wounds or gunshot wound. Or a steering wheel can get your chest and can get your abdomen as well. So any procedures that are being done to the patient, any invasive thoracic procedures can cause some of these things as well. So if we've got fluid in the chest, we may be going in to do a thoracentesis to get stuff out, and we can cause the lung to collapse by doing that. Inserting central line very often will cause, that's a common complication of inserting a central line, is to cause a pneumothorax. A pneumothorax. And so that's why we always, two reasons, we always get a chest x-ray after the insertion. It's one, to make sure we don't have a pneumothorax, and two, to make sure the placement is correct before we start pushing in fluids or what have you. So just some of the things you will see. Let's see. Barotrauma, again, over pressurizing during ventilation, and when Ms. Cobbs talks to you about that, you'll be going, oh, Ms. Lee talked about that. So when we get these traumatic, the open pneumothorax, we have that sucking chest wound, not only does the lung collapse, but the heart and the great vessels shift, because on inspiration they shift toward the uninjured side, and on expiration they shift toward the injured side. So it swings kind of back and forth. But that has to do, it'll show you about how the tamponade did, how it would make that mediastinal shift. Well, these will do that as well. So those are things we're always looking for, that the trachea and all to be midline, and when it's not, there's usually something odd going on. Okay? They happen fast, and they can be quickly fatal if not taken care of. And especially the tension pneumothorax one, and I may have a picture of that here in a second. The tension pneumothorax, that is a big one. That has to be what they will often do, like real quickly in ER, if it's a tension pneumothorax, is they'll just put in a real large bore needle. They have, all this stuff down there. In olden days, they didn't have as much, but they'd put that in just to let that air out, because the air just gets trapped in there and keeps every inspiration, it gets more and more, and it puts more pressure on the working lung that's not collapsed, and on the heart and the vessels and all. So they have to relieve that quickly, or it'll be fatal. Okay, hurrying right along. Here's a good picture. Like pictures, the pneumothorax showing air, diagnosed by chest X-ray and arterial blood gases, and you see what some of the causes can be. Ruptured bleb from COPD, thoracentesis, traumas, what have you. It can be even from, they get an infection because of these traumas or bugs introduced, and you see what their symptoms are. Okay, there's the symptoms again. Subcutaneous emphysema, or crepitus, is something that's where air leaks out into the tissue around the injury and feels like Rice Krispies under the skin. It kind of feels like those packing bubbles a little bit. You just kind of feel it, and So if you ever have a patient with it, they were very good to let you come in. They're usually real tickled that they have something that is not going to hurt them, and they're glad to help you with your education. So go in, ask them if you can come in and feel it, and what have you. So cool. Of course, the goal is to get them back. Either get air out or get the blood out, and get them doing better. And like I said, small chest tube for pneumothorax will go up high to get air out because air rises, and the pneumothorax, a larger one, down lower. And they usually will put these to 20 millimeters of mercury suction. And I hope there's a picture in your book about chest tube in chapter 32. Yeah, there you go, on 32-17. And it also talks about 32-14, a chart about best practices. So I would want to look over those really, really good. Antibiotics certainly is going to be something they're going to be getting. Thoracotomy might have to do if we've got more than 200 mLs of blood drainage per hour, greater than that, because that's a whole lot of blood, and we don't expect that. So if we're getting that much, they're going to have to go in, the surgeon is, and explore and find out where that's coming from and stop it. Okay? So often these are called pleurovac. There's another name, and I can't think of what it is, the dry one. But you can see how to fill these up, and you can go on the internet, and you can look this up. It's wonderful. But on those charts that I just told you about, really good to walk you through it. They're quite simple to set up. It just sounds cumbersome, but once you see it and it's got directions on it, it's real simple. You just have to know what to do with it once we get it up. That's not the simple part. Okay, so in the olden days, we'd put petroleum gauze around the insertion site. I have not seen that happening as much now, but I'm an old dog, so I still do it. But that's just fine. I'll talk to you about the bubbling and what have you. We'll go over some of that. Okay, so here we've got a picture of a person, and this is their cross-section of them. You see this tubing is put in, the small tube, up high to put air, let the air get out so that the lung can expand. Because if it gets caught up in here, the air gets bigger and bigger and bigger, and the lung can't expand. And then this one is down here for drainage, lower for drainage. And you see this is on the outside showing kind of how it goes. Hemothorax we talked briefly about. There'd be blood being in there instead of air, and certainly that compromises the patient. So, and a simple is 1,500 mLs of blood into the chest cavity, and a massive one, I guess so, is more than 1,500. Woo, that's a lot of blood. So that's something urgent. Like I said, if we're getting, that might be the initial thing, but if we're getting more than 200 an hour, they're going to start doing something. They're going to start. I think I've got my numbers mixed up here, but I'll look that up. Okay, chest tubes. We're going to mark the drainage every shift. We're going to try to keep it kind of like how we do with a Foley. We don't want it dragging down and laying in the floor and what have you. We want to keep it up and no kinks and loops in it. We don't want to strip or milk them. That's where we'll, put like, I don't know how to explain it. Kink it up and pull down from the patient to the tube. That puts too much pressure. We don't do that. That's stripping or milking. We don't want to do that very much. But we do want to get clots out and that kind of thing. So we might do some gentle hand over hand pressing on it to. We'll see. Observe for air leaks. We don't want to clamp these tubes during transport. We want to keep the apparatus lower than the chest. Usually we'll have the patient doing some incentive spirometry to help to expand the lung. That's painful. Coughing and deep breathing. And when do we know that the chest tube is ready to be removed? When the lung re-expands. And they'll do serial chest x-rays daily, sometimes twice a day, depending on the patient's condition, to see when it's removed, expanded. And a lot of times what they'll do too is the doctor will come in and clamp the tube like one evening and see how they do through the night, or either clamp it in the morning, see how they do through the day, and then take it out that evening. So and that we will help doing that too. The titling, what that is when you're looking at the system has, the Pleurovac has three kind of separate places. The first column comes from the patient and has the fluid or air, whatever, in it. And then the second column is the suction chamber. And the third column is the water seal. And the water seal, and it shows you how much water to put in it, how to do it, and the instructions are right on it. You can't mess it up. If you tried, you couldn't. And the titling is when they're taking a deep breath or letting out or coughing or what have you. You'll see the between the patient and the water seal, I believe it is, that you'll see the fluid kind of rise and fall. The only place there should be continuous bubbling is in the suction control column. There could be mild bubbling there. Or if we turn the machine up to 1,000,000 and there's only so much water, will only allow so much suction. Doesn't matter if you have Tim Allen there with a it won't allow it because there's only so much water, and that regulates the pressure. But that bubbling is okay. Bubbling over in the patient drainage and the water seal means that either we need to add some for the water seal or there's a leak, probably a leak. So sometimes we will be checking that, and we will go down close to the patient and where he's connected to the tube and gently with a padded clamp that off. And if the bubbling continues, then it's probably inside in the patient, so we need to no, that would be the bubbling wouldn't be there. It would be the machine might need to be changed out. But if it back on that, I'll think on that and have you some questions to make sure we've got that correct, because I don't want you to me to give you some crazy information that doesn't make sense. But when you look at do some videos and look and see, and also read in your text about how to set up Pleurovac, it's very simple, very simple. Remember about the tension pneumothorax. I said that is a life-threatening thing. I don't know why I've gone back. I guess because I just barely mentioned it, and I'm just going back and hitting on it a little bit more. That's the one that is life-threatening. It's got to be corrected. Air's forced into the chest cavity, makes the lung collapse, and it'll also give you that shift of the mediastinum. Let's see. Okay. There you go. That shows that there's the midline. That's how the trachea is. And see here, this one's collapsed, and press it goes that way. Okay, so it goes, it's called a mediastinal shift. You've got to get a relief here to let this lung re-expand, because this lung is going to get compromised. Okay. Why don't we stop here at pleural effusion, and I'll continue on. Thanks.